So I'll be talking on what we're doing in the undergraduate BPharm program from the NMMU point of view. And I'm effectively reporting on the last couple of years. Our new BPharm curriculum was implemented 2013. We've reorganized our program to 3 different streams, and what I'll be talking about is really focused on the clinical stream. But I'm going to start with where we begin. So as I go through the curriculum, I'm just picking up on the yellow highlighted. So preparing the students, we start in first year, obviously, with the anatomy and physiology. That runs over both semesters. Then in second year, we pick up again, as they start introductory pharmacology, looking at the acute inflammatory response, the immune response, etc. And then we really start preparing for antimicrobials when we look at the microbiology module, which happens in the second semester in second year. Then in the third year of the BPharm curriculum, the clinical pharmacy module, which is an integrated module, focuses on antimicrobials. So I'm going to just tell you a little bit about that module. It's 18 credits, which means 4 lectures a week, 4 double lectures, and a 4-hour prac each week. So it's quite intensive. And we also start our clinical placements rounds that year. Then in fourth year, it's pure application. We're in our second round of clinical placements, and that's a much bigger module of 30 credits. So just looking at the preparation, there's core material or core knowledge starting from first year with anatomy and physiology, then moving through to the integrated clinical modules, and then finally the application with the experiential learning programs. Coming back to the module itself, we start off with introductory lectures, a little bit on infection markers and lab investigations. Included in that is something on antimicrobial sensitivities. And we also just have about 4 lectures on medical microbiology, just to remind the students not to forget what they did in second year. That module really is very pharmacology and therapeutics intensive. It's an integrated module, so we also have some medicinal chemistry there. And then when we look at the pharmacy practice side, we're bringing in the role of the pharmacist in the primary care setting, starting to look at pharmacist-initiated care with colds and flus, immunization campaigns, etc. The practical sessions are arranged around group learning exercises. We use a lot of clinical case-based scenarios, obviously trying to cover as many infections as possible. And then we round off the module with a guest lecturer. It's one of the antimicrobial stewardship pharmacists. We're lucky that we have 3 private sector hospitals in Port Elizabeth, all running programs. So we have some expertise we can call in. Then the application comes in with the experiential learning programs. The students do work-based learning clinical placements in their recess. It's 2 weeks in the third year, 3 weeks in the fourth year. Those placements, the students are supervised and assessed by preceptors in the workplace, and they're very structured. They have a manual of tasks and activities to complete. So the third year is focused on the community pharmacy setting. The fourth year takes place in a hospital setting. So in the fourth year clinical placement, the students actually have a specific task where they evaluate the hospital that they're placed in terms of parameters used for antimicrobial stewardship. The other aspect is the hospital program itself. So this is a 15-week, 12-hour per week program, which sees our students out in our 4 hospitals in the therapeutics module. Obviously they're extensively exposed to HIV and TB management and, of course, acute infections. They have weekly activities to complete. They have to write up patient case reviews. They have to review patient medication on a daily basis with the idea that they're picking up pharmacist interventions that they can then talk to the staff about. We assess this module with an open book format. The students have to answer clinical case-based questions. It's a written exam, obviously, and it's quite a high level of learning. It's an analysis type of questioning. And then, being an open book, we obviously guide them in terms of references, and they are expected to arrive with copies of the evidence-based South African treatment guidelines for HIV, TB management, community-acquired pneumonia, etc. So that they will have been using during the year and then use in the exams. Other policies or implementation of the AMS that we've brought in is looking at the antibiotic prescribing pocket guide. We use that as a dedicated practical. In the third year, the students actually obviously exposed to this guidelines. They use them in the practical with the idea that they then know about the guidelines and take it through to fourth year when they're in the hospitals. The second is that we recommend that they sign up and complete the South African Antibiotic Stewardship Program's online course. We don't enforce this, we haven't so far, but we've encouraged the students to do it. I suspect probably the good students do it. I suspect not everyone has, but we've made them aware of it. And then I think just to finish off, observations at this stage, and this is not only just with the new program, it's going back over the many years. What are the areas for improvement? Because we're at the point now we also need to start reflecting on what we've done so far. And looking at our students, the one thing I've observed is they really struggle to integrate information when we need them to look at the type of infection, come up with the likely causative organisms, and then recommend appropriate antimicrobial. They're not that comfortable with this full integration of what we would like them to be doing. And secondly, we need more on antimicrobial dosing guided by MICs. That's probably a big gap at the moment. But it leads on to the next problem. If you look at the academic staff perspective, we have a dire need to develop expertise. It's very difficult for staff trying to set clinical case scenarios when they're not working in the clinical environment. So there's a limit as to how far we can get without lots of expertise coming from practice to help us. So we're at a point now where we need to start developing that. Thank you.